Now into a fourth year, the COVID-19 pandemic has had a profound impact on health workers on the front lines. In particular, it has impacted women, who have led the response to the pandemic in the health sector, holding 70% of health worker jobs and over 80% of nursing and midwifery roles. Women health workers, from doctors to community health workers, have worked tirelessly, risking their lives. They've suffered wearing inadequate personal protective equipment designed for male bodies, leaving them vulnerable and feeling undervalued. On top of the increased patient load, women health workers have shouldered additional hours of unpaid care work, often managing their families, elderly relatives, and households. With women earning 24% less than men in the sector, and many working unpaid or for low stipends, the pandemic's economic shocks have hit women the hardest. Here's where the story takes a turn. Women are saying enough is enough and voting with their feet. A global trend in the health sector is emerging: the Great Resignation, with evidence suggesting that many women health workers, especially in high-income countries, are leaving or planning to leave the profession. This trend unfolds against the backdrop of an already alarming global health worker shortage. According to the World Health Organization, there was a deficit of 15 million health workers even before the pandemic started. Lives have been lost, and many women health workers face long COVID. Mass resignations have struck the sector, with nearly 1 in 5 health workers leaving in the USA alone. Across the Atlantic, the UK saw over 27,000 staff volunteers resign from the National Health Services in the summer of 2021. Men and women are leaving the profession, but we focus on women health workers because they are the majority, and the measures urgently needed to retain and recruit them will largely be determined by gender. We urgently need coordinated government action to address health worker attrition in the short term and formulate long-term, sustainable solutions without resorting to unethical international recruitment. The pandemic has cast a glaring spotlight on the role of women health workers and the inequalities they face. To retain and attract these women back, we must usher in gender transformative change, ensuring equal leadership, safe and decent work, and fair pay. Women in the health workforce deserve a new social contract, one based on equity. This contract will enable them to deliver health for all. Join us in taking action to address the Great Resignation and support the woman at the heart of global health.
Hello, everyone. On behalf of Women in Global Health, it is my pleasure to welcome you to this virtual event to the launch Women in Global Health news report, The Great Resignation, Why Women Are Leaving. My name is Sandra Yarza Torres. I'm a midwife, president of the International Confederation of Midwives, and a member of Women in Global Health Board, and also one of the founders of the Women in Global Health chapter in Chile. Before we start, we would like to talk to you with some few housekeeping points to be aware. Please introduce yourself and make comments in the chat. We want to know all of you and also want to talking to you, during this special time. Translation is available in Spanish and French. Click on the bottom right-hand button of the globe to access your desired language. Join the conversation on social media using the hashtag #GreatResignation. Last year, I participated in Women in Global Health events on the Great Resignation at the World Health Summit in Berlin. The issues we discussed: health worker shortages, the impact of pandemics on women health workers, unprecedented resignations, alarming migration of health workers from low to high-income countries, sadly continue to be of huge concern. They are critical issues for all health workers, especially midwives and nurses. During the pandemic, I have seen how midwives of all ages have taken sick leave or resigned. Some have had enough of this inhuman system. and retire early, while early career women are not willing to tolerate such poor and stressful working conditions. The issues we're discussing today matter for women. They matter for health system, and of course they matter for everyone. Thank you so much for joining us to mark the publication of this important report. I am pleased now to introduce our first speaker, Ambassador Delphine O, to share keynote remarks with us. Ambassador Delphine O is an ambassador at large and Secretary General of the Generation Equity Forum between 2025 at the French Minister of Foreign Affairs. She was previously a member of the Parliament, a member of the Foreign Relations Committee, and a chairwoman of the France-Iran Friendship Group. Ambassador O cannot join us live today and has recorded her message in a video for us. Let's join her.
Thank you to Women in Global Health for this important report and for organizing this event and for the opportunity for me to share this message. More than 3 years of the COVID pandemic have deepened pre-existing gender inequalities in society and within the health workforce. We know that women health and care workers have made an exceptional contribution on the pandemic front lines, but they were paid less, they were protected less, and had little decision-making power. They also carried an additional burden of unpaid care and domestic work at home or in the community. Against the backdrop of increasing gender inequality linked to the impacts of the pandemic, with Women in Global Health, the government of France launched the Gender Equal Health and Care Worker Initiative at the Generation Equality Forum in 2021, because we recognize that health system cannot function without women. We also recognize that gender inequalities in the health workforce, including in leadership, in pay, in protection, reduce the morale of women workers and also mean that health systems are not fully benefiting from the talent, the engagement, and the professional knowledge of women. This initiative addresses gender equity in the health workforce along 4 pillars that I know will be discussed today. The first pillar is about promoting equal participation of men and women in health leadership. Although women are the majority of health workers and have been the vast majority in the front lines during the pandemic, they hold only 25% of senior decision-making roles. The second pillar is recognizing the value of unpaid work, largely done by women in the sector, and the importance of equal pay. Research by Women in Global Health identified over 6 million women working in core health system roles are unpaid or grossly underpaid. In general, women health workers earn 24% less on average than their male counterparts. The third pillar is protecting women health workers against violence and harassment. This is a universal and yet completely preventable problem. It harms women affected and also harms health system. The fourth and last pillar is about ensuring safe and decent working conditions for health workers everywhere, including personal protective equipment, vaccines, and addressing the mental health needs of health workers, which has been a major issue during the pandemic. These are all critical areas to address if we were to retain women health workers. Since we launched the initiative 3 years ago, we have seen the power of working collectively to address the challenges faced by women in the health and care workforce. This initiative now has 18 governments representing all regions and over 40 organizations, including multilateral organizations. At the national level, the government of France has engaged in several forums in the last 2 years to recognize and value the commitment of health and care professionals to the health of the French people by investing more than 20 billion euros. At the international level, France has just published its new global health strategy, which identifies human resources as a top priority of our action to accelerate progress towards SDG number 3. In this new roadmap, we're calling for efforts to promote gender equity among healthcare professionals to be stepped up. The gender-specific dimension is therefore systematically included in our French international cooperation programs and projects. Health system cannot function without women health workers. The predicted global shortage of 10 million health workers by 2030 is deeply concerning. We will not stop women leading without addressing the root causes which lie in the gender inequities they face within the health workforce. Urgent intentional and international action to address gender inequity in the health workforce is needed. I thank again Women Global Health for this report and the organization of this event, and I wish you a fruitful discussion. Thank you very much.
Thanks so much to Ambassador Paul for that amazing message, and to the government of France for their continued support to advance gender equity in global health. And let's keep us in mind Ambassador O's words: leadership, pay, protection against violence. I'm now pleased to introduce Dr. Anne Tilling, Women in Global Health co-founder and senior fellow, who will share with us some of the key findings and recommendations from the report. Dr. Anne?
Thank you, Sandra. And I think that short video and our introductions have really said so much. And I'm really pleased to be presenting this report on behalf of Women in Global Health. And the bottom line is that women are leaving the health profession. And this is a serious global problem. Thank you, Rachel. And the background is that we already had a global health worker shortage before the pandemic. Of 15 million health workers, but also within that, nearly 6 million nurses, nearly 1 million midwives. And that governments have noted health worker shortages in recent political declarations from high-level meetings on pandemic preparedness and response and universal health coverage. But the pandemic, with all its sudden surges of patient numbers, etc., and stresses, came upon the pre-existing gender inequities in health systems that women were already suffering. And that means being marginalized in leadership, being paid less, inequity in career progression, and also inequity in protection from both disease, but also other forms of violence and harassment. And women in general in global health, although they're 70% of health workers, they hold only 25% of senior roles. And that hasn't changed in the last 5 years, according to our data. The pandemic impacted all health workers, but it impacted men and women differently in the health workforce. And the measures that we need to retain women are going to be different because of the gender roles that they play in society. Thank you. Very briefly, this was just our summary of some of the impacts of the pandemic on women in the health workforce, sidelined in decision-making and leadership, in the health systems that they know best, at higher risk of infection, often last in the queue for PPE, and more than that, often given PPE designed for male bodies, which did not keep women safe and left them working in undignified conditions. Women, health workers, have long been subject to sexual exploitation, abuse, harassment, and violence at work. And this and gender-based violence at home increased during the pandemic. Women health workers, as I think we would expect, suffered from an increase in mental stress, PTSD. We've seen that across the board. And yet in the middle there, we're listening to women health workers telling us that they feel tremendous pride and professional satisfaction in the role that they played in the pandemic. And yet, despite what women health workers have done for us, we have not always repaid them in the way that they should have done. Thank you, Rachel. And here are some examples where we are seeing these examples from all over the world, that during the pandemic and afterwards, women suffered from a lack of fair pay and unequal support during the pandemic. So in Japan, 73% of nurses experienced unfair treatment. They were forced to take shifts. They were forced to take unpaid leave. Brazil, women doctors are describing a similar rigid work schedule that took no account of the other pressures that women were facing during a pandemic as the primary caregivers for children in particular. Again, Ireland, women nurses being forced to choose between caring for their children and coming to work. And Canada, midwives noted they had to take time off work during the pandemic because they couldn't get the support that they needed outside work. Thank you, Rachel. And so what we are seeing across the board is significant numbers of health workers and significant numbers of women, because women are the majority, retiring early, leaving the profession, and in many cases migrating. And this is generally due to the pandemic having created a perfect storm for women, because it came on top of all those things that we've already talked about, unequal burden of work inside the health system, but also outside it as well. Not all health workers under stress will be able to resign. I think we will see more resignations in high-income countries than we might in low-income countries, where women are simply unable to leave their jobs. But we should also consider the impact of health workers staying on the job when they are burnt out and under stress. Thank you. And we don't have very good data as yet on the Great Migration that we see starting of health workers, and particularly women health workers. And women health workers are migrating from high-income countries to high-income countries, but we're also seeing very high levels of vacancies in high-income countries and intentional measures to recruit women health workers from low and middle income countries. And this is the Great Migration that we are seeing that is already underway. Thank you, Rachel. So our key messages from this report is that the COVID pandemic did not hit men and women in the health workforce equally. It deepened existing gender inequities, and women health workers are burned out and resigning in significant numbers, and this is contributing to the Great Resignation. And that this resignation of women health workers in high-income countries is driving a great migration from low-income countries, further weakening vulnerable health systems that were already under pressure, short of health workers and short of trained health workers. And this is going to have a huge impact on the achievement for those countries of global goals like universal health coverage, and just simply on the delivery of a decent standard of care. There is an urgent need for all governments, and particularly governments in high-income countries, to implement national health workforce plans, long-term plans, to emphasise both the retention of health workers and to take measures to aid the re-entry of the health workers who've left. I'm sure that we all understand it takes years to train a health worker. So although we should be talking about the training of health workers, and we should be looking at ensuring sustainable domestic supply wherever possible of health workers, we should at the moment be looking at retention and trying to attract back the health workers who have left. And we need to take global efforts because this is a global problem. This is an interconnected world, and the pandemic has shown us that loud and clear. But global efforts to prevent vulnerable countries from losing their health workers especially to high-income countries. And currently we're seeing high-income countries, and this is documented in the report, creating strong incentives for health workers from low-income countries to migrate. In 2010, governments agreed to the WHO code on international recruitment and migration of personnel, of health personnel. That code now seems to us not to be working in the way that it should be. There are red list countries where high-income countries are not supposed to be actively recruiting health workers, and yet we see that happening. So there's an urgent need to review the 2010 WHO code, but also to adhere to it. Thank you. And our recommendations. I think, as I've said, the urgent need now is to focus on retention, training of health workers for sure. But let's focus on retention. Let's look at what those women, what those other health workers need to come back into the workforce. Let's operationalize the 2022 WHO Global Health and Care Worker Compact, which has been agreed by all WHO member states to ensure dignified, safe and decent work for all health workers, especially women. We need to prepare for pandemics and health emergencies. There will be future pandemics. This is not the last one. And we need to be ready for the next one in the way that we have not been ready for this one. We need to be looking at engaging all sectors and stakeholders in health workforce planning. In many countries, the private sector takes a leading role in health service provision. So all the agreements that do exist, including the code, must be adhered to not only by the government sector, but also by the private sector and by NGOs as well. And in all of this, we must be intentionally addressing gender equity in the health workforce. This is a gender issue. And if we don't intentionally address the reasons why women are leaving in particular, we will never solve this problem. Thank you.
Thanks so much, dear Anne, for sharing with us this report. It's really touching in our hearts, I think, your message, of course, and we have to keep in mind what you said at the end, that let's focus on retention and training of the workers on dignified and decent and protected work environments. Because it takes years, as you said, to train health workers. Of course, we should be thinking about, ensuring this enabling environments for them. So now, as we go on with this panel, we are privileged to hear from Juliana Essel, a health worker from Ghana who currently lives and works in the UK, who will share with us her message. Thank you, Juliana.
Good morning. My name is Juliana Posha, 45 years old woman from Ghana. I started my early life after secondary school at a hospital called St. Martin de Porres Hospital as an Audrey after my secondary school. They sponsored me. I went to Akemodan Nursing Training School. I pursued 2-year course and I became a community health nurse. I worked with the hospital for 5 years where I met my late husband. And 2008, I moved to Takrady to stay with my husband. Unfortunately for me, my husband passed on. The salary wasn't good, but because of the support of my husband, I was okay until he passed on. So after the passing on of my husband, I pursued a degree course at University of Ghana, general nursing. I was still working at Takrady Hospital. After my education, I was transferred to a chief compound at Jemima Hospital and later came to Kwesimintim Hospital to do my service. After the service, it was another story on its own. I was not promoted My salary was nothing to write home about. I was still receiving community health nursing. Meanwhile, I had another child, adding up to 3, and it wasn't easy. So the man I was living with, my second husband, it was like hell for me. I became a punching bag, calling me names, useless, disgracing me left and right. So life became unbearable. With this salary that I was taking as a community health nurse, still my promotion was not done. I have to resort in selling secondhand goods, go up and down with, after work, I will go and sell so that I can feed my children. I couldn't watch my children to starve. And it continued until 2021, thereof getting to the end of the 2021, because before I was promoted. And looking at the salary I was taking then as a nursing officer with these 3 kids, with the school they attend, it was hell. And the husband that maltreated me, I divorced, and he was not even giving me peace, always insulting me when it comes to taking money to pay his own child school fees, feeding his own child. The money, if I ask, it will be a war. I just sat down one day, I said, no, I have to look elsewhere. Because with this Ghana Health Service, the salary I was taking, I don't know what I'm going to do. I became stressed so much, I don't even know. At times, it felt like you have to end it all because of what I was going through. I wake up each morning, look at my children. Feeding them is a problem. Unless I call some of my late husband's friends to say, I don't have money, give us money. A time came when you even call them, they won't even pick up because they know you are coming to ask for money. So I decided, no, I have to do my best for my children. I have to live for my children. And I applied for a carer job at the UK, and I was accepted. I got a certificate of sponsorship, and I left my job. I resigned as a nursing officer and moved to the UK just to become a carer. And now thinking of writing my exams, doing the necessary things to join the NHS. Although I came as a carer, but I'm much better off than living in my own country. Much better off. I can now pay my children's school fees. I didn't come with them, they are there. But now I can pay their fees, give them a better life that a mother should give. So me migrating from my country just to become a carer in somebody's land is nothing more than giving the life of my children a better life, to give my children a better life. So I have to do anything as a mother to give my children a better life. So I have to accept and come to the UK to be a carer. I'm a carer, I do live in, pop in. It's not easy. Still, it's better off than Ghana. It's better off than my own country. I can now boldly say, with even my carer work, my children can eat and sleep, and their school fees are being paid, and they are able to wear better dresses as their colleagues. As a child, what is supposed to get. So me moving in here wasn't a mistake. It's rather a blessing. If not for me, I did it for my children. So I know at the right time I'll move to the hospital and my dream will be fulfilled. So that is my story. Thank you.
Thanks so much, Juliana, for sharing your story that, of course, shows us how hard it was, not just for the clinical work, but also as a personal life, as a mother, as a woman, as a sister, as family. We can all feel what you just shared with us. And now it's time for us to turn our high-level panel. And I'm really pleased and honored to introduce our speakers for this panel. First of all, we have Maren Hopsa, is a technical officer in the Sector Policies Department of ILO, who works on promoting rights at work, encouraging decent employment opportunities, enhancing social protection, and strengthening social dialogue in the health sector. You also have Mrs. Banton Foyleban from the USA. It's a top leader in workforce development and a catalyst for economic mobility through higher education. Currently Brown is the CEO of the Futuro Health, whose nonprofit mission is to improve the health and wealth of communities by growing the largest network of allied health workers, including community health workers in the USA. Also, we have Ms. Betty Goulding-Geddick. Dr. Geddick is the coordinator for the WHO Eastern Mediterranean Regional Office on Health Workforce. She started her career as a general practitioner at district level and then worked for the Turkish Ministry of Health on national health policy development and healthcare reforms. She has worked on health policies and systems in Central Asian Republic and WHO Regional Office for Europe. And finally, we have also Ms. Aileen Estrada. She's the National Secretary of Chilean Midwives Association and a member of the Women in Global Health Chile chapter. She has 12 years experience in clinical care, and her career has included extensive work in management, in public service, and higher education. So it's an honor to have you all this morning, this afternoon, and we will have not that much time, but we are really thrilled to hear your thoughts. And we will go to our first round of questions. And my first questions will be for Julian from WHO Emerald to give us a regional perspective on these issues that we just been talking about. So, Julian, how are the Great Resignation and migration trends playing out in the WHO Eastern Mediterranean region? What are the different challenges and how are you responding? Julian?
Thank you very much, Sandra. And thank you very much for organizers for inviting me. I think I just would like to start giving a little bit of background for the region that I'm working in. Eastern Mediterranean, WHO Eastern Mediterranean region hosts 22 countries stretching from Morocco to Pakistan on the east. And it's home for 750 million people. And the region has got some low-income countries as well as some of the highest income countries. So we have quite diversity and different challenges in the region. And also half of the countries in the region face some kind of protracted crisis. So first of all, in our region, we face overall shortage of health workers. And when the projections made shows that these shortages will continue. I mean, the projections for 2030 indicate that these shortages will continue, and our region will account for 20% of the global shortage of health workforce and actually accounting for 75% together with EMRO. So with AFRO, so these two regions are globally prioritized for health workforce issues. And 6 countries in our region is in the WHO support and safeguard list. This list shows the countries which are most challenged with health workforce issues in advancing universal health coverage. So part of our region has got difficult working conditions and face shortages, and those same countries face difficult working conditions. I mean, as I mentioned, half of the countries are in protracted crisis. Not only the safety and security of the health workers are in threat, and of course, inadequate working conditions, and in some countries they are not paid for long periods. These are all creating some stress on our health workers. And also some of the countries are facing economic crisis, which is also another factor increasing the stress on our health workforce. So all these increase the international mobility of health workers in most part of the countries. And there are some countries in our region which are heavily reliant on expatriate health workers. and they are also trying to nationalize their health workforce because of the sustainability concerns. So, of course, COVID-19 pandemic highlighted some of the challenges further. And for example, even in some countries where we have shortages, we also suffer from the limited employment capacities, either due to administrative limitations or financial limitations. And also there are gaps in certain, not only overall shortages, but gaps in the skill mix. For example, shortages of nurses, or COVID-19 highlighted some of the areas like ICU workforce or public health professionals, pulmonologists, etc. And also we know that more and more we recognize the importance of protecting and safeguarding health workforce. COVID-19 put it into our radar once more. So all this highlighted that we have health workforce challenges. Over the years, there has been some efforts to address these health workforce challenges globally and regionally. As you know, we have global strategy on health workforce. Then we have a regional framework for actions for development of health workforce. And you all know there are a number of global strategies, guidelines developed to address health workforce challenges. So we have some commitments. But when we look at the progress, it is not at the desired level. So 2 weeks ago, we had our regional committee in our region, where our ministers of health came together, and they recognized that we need to accelerate the actions to address health workforce in the region. And they unanimously called for accelerated actions. And this is a call to invest more in health workforce in the region, invest in production capacities, but not only in production capacities, but investing in smarter has been highlighted, investing in employment capacities, investing in where we have gaps, like strengthening primary care workforce to deliver essential public health functions and emergency response. And also, this is an investment to protect and safeguard our health workforce with decent working conditions, regular adequate remuneration, and also, of course, to address increasing international mobility with the protracted crisis and economic crisis. So this is calling for international cooperation, more dialogue among the countries, and more solidarity, strengthening the health workforce in each country. So I think the whole call emphasized that, and which is part of the Global Code of International Recruitment of Health Personnel. Each and every country needs to strengthen their health systems and health workforce to address international health workforce mobility, and we need to invest more in more solidarity. Maybe I'll stop here. I know we don't have much time, Sandra.
Yeah. Thanks so much, Dr. Golin. Really enlightened what you just shared with us, and we just keep in our minds and our heart the need that we have to accelerate the actions at regional level and at global level. Thanks so much for these thoughts. So now we go to turn to looking at a global picture, and I turn to Maureen from the ILO, and we would like you to share with us what is the global picture when it comes to working conditions for women health workers. Maureen?
Yes, thank you very much. And first of all, I would like to thank the organizers for inviting me, and for also for organizing this very important event, and a huge congratulations to Women in Global Health to the launch of this report, which actually very, very nicely shows the multiple and the complex challenges that health workers, and specifically women health workers, are facing. So when I saw the question, the global picture of work, the challenges in terms of working conditions, basically I thought, the report actually answers this all very nicely already. It's shows, and also the the comments and the inputs that we've heard in this panel already show the difficult situation that women are facing with regard to working conditions in the health sector. So as mentioned, there is no doubt that the health and care workforce is highly feminized. I mean, the female rate in the health workforce far exceeds presence of females in total labor forces in most of the country. However, we also see that women often concentrate in lower skilled jobs with less pay and at the bottom of the professional hierarchies in the health sector. And as the report shows, I think gender discrimination and inequality in the health and care workforce are key barriers to entry, re-entry, and retention of skilled and qualified health personnel. We also see that women often face barriers to full-time employment, to leadership positions, and they have challenges with regard to career progressions, as we've also heard in the very touching statement from Juliana before. I think the list of challenges, of decent work challenges from a global perspective is super long, but I just wanted to highlight very, very few ones here. And again, it's not an exhaustive list, but we see that there is an underevaluation of the care work. In most economies, workers in highly feminized sectors receive lower earnings than workers in non-feminized economic sectors. So although we see an increasing number of men joining the health and care sector in recent times, the high degree of feminization contributes to the sector's under-evaluation by society, with average earnings lower than in other sectors. And it has been argued that the labor market devalues so-called female tasks and skills. So care work is initially seen as a women task, taking care of the children, of elderly, of people and relatives in need. And we know that the fact that where women's share in the workforce or in an occupation increases, often wages decline. So that is something from a global labor market perspective that we see. And we see that in the health sector with the gender pay gap. Then the issue of decent working time. So a lot of women struggle to balance work and care responsibilities. And there is a difficulty to cope with these growing expectations, which leads to a lot of women taking up part-time jobs and remain segregated into female majority jobs. They take leave for fulfilling the caring roles. While this might provide the needed flexibility to address changing demands, oftentimes health personnel, women and health workers are often experience increased precariousness through this, job insecurity, lower pay, increased occupational safety and health risks, but also gaps in social protection coverage, and challenges to forming and joining unions and exercising their collective bargaining rights. And also there we see that female health workers are increasingly under risk of experiencing violence and harassment. We know that the sector itself has been recognized as one of the sectors with a high risk of workers experiencing violence and harassment. This has been recognized in the recommendation accompanying the ILO Convention on Violence and Harassment, Convention number C190, and it calls upon member states and on countries and governments to gather with workers and employers representatives to address and to design policies to address the issue of violence and harassment, especially in those sectors like the health sector where the risk is very high. So maybe just to summarize, I think we know a lot of challenges, but what is actually, what do we need, and what do health workers and women health workers need to perform effectively? I think they need employment opportunities, they need adequate pay, safe and healthy working condition, access to quality education and training, opportunities for career progression, equal treatment, and of course, access to social protection. So I can only join and emphasize the call for increasing investments in the care workforce, but they need to go beyond extending the numbers, but also need to address the decent work challenges that we're seeing and ensuring that all health workers enjoy the rights at work and enjoy decent working conditions. I stop here. Thank you.
Thanks so much, Marin. And we just keep in mind and the heart, of course, this call that to invest in health workforce, to invest in women, to invest, of course, in strength, women's voices, the health workers are there. Thanks so much. So now we will move on, of course, and looking now at the specific context, I want to ask Ban, what can we learn from your work in the US? How
Well,
can
thank-
community how can community-based health workers help to address health work shortages in the US and elsewhere? Then,
well, thank you very much for having me. Well, Ms. Marenhoff's comment about the feminization of the care workforce reminded me of a recent panel I was on, specific to the future of work. It was a future of work discussion. And again, others on the panel pointed to care roles as being, quote, safer from automation. And while there are many, many good jobs in the care economy, as we all know from this report, what's troubling is that so much of care falls disproportionately on women and women of color. And so if the low wages of roles like home care workers and nursing assistants in nursing homes and residential care and community health workers fall in the care economy, then we have a troubling future work to look forward to. And so much needs to be done in terms of changing the narrative of the value of these care roles. So specific to community health workers, as we all know, it takes a trusted member from the community to provision care to the community. And so much, hence the increased use of community health workers in the US, following the best practices of many other nations. Most notable since the pandemic is that there were recent policy efforts to fund and reimburse the services of these community health workers so that they do not need to be grant funded, which should provide more stability and growth to this workforce in the US. I chair the California Healthcare Workforce Education and Training Council. And as you know, California is the 5th largest economy globally. And in this state alone, what we see in the council is that is there a shortage of primary care doctors? Yes. Is there a shortage of specialty nurses? Yes. Is there a shortage of oral health workforce? Yes. Is there a shortage of allied health workforce? Yes. Is there a shortage of mental behavioral health workforce? Yes. So the list just goes on and on. And so with the continued shortages that we see pervasive in all of these different areas of care, we can expect to see more use of paraprofessionals, those like community health workers, and also certificate trained in less than a bachelor degree, in order to augment the care team. And so, yes, we see the increased use of community health workers since the pandemic, but also to address all of these areas of shortages in care. There will be many more roles that come about just because we have to deal with the shortage of many of these professionals.
thanks so much, Dan, for sharing with us, of course, this important thoughts and reflections. And finally, we come to Eileen. And Eileen, please, could you share with us how has the COVID-19 pandemic impacted you and your work? And how does this report resonate with your experience? Eileen?
Hola Sandra, hola a todas. Muchas gracias y estoy muy contenta de poder participar en esta presentación de este increíble trabajo que han desarrollado ustedes. Bueno, primero que todo quiero contarles que a pesar de que Chile no fue uno de los países estudiados, puedo decir que concuerdan en la gran mayoría de las conclusiones escritas en este informe con la realidad que vivimos en mi país, en Chile. Yo fui matrona en un hospital público de alta complejidad durante la pandemia, en donde en el principio de la pandemia no nos querían dar elementos de protección personal porque creían que las mujeres embarazadas no se iban a contagiar porque no eran personas enfermas. Para revertirlo y poder obtener los resguardos mínimos, tuvimos que pelear como asociación, tuvimos que implementar estrategias de prevención sin ninguna normativa central.
Safety measures and a central rule because we were getting sick people sicker, and we started to slowly integrate sexual and prevention personnel into this union. Each week the rules would change and we have to continue on real time, adapt our rules. Personally, I had to explain 80 people who were made up my team why the contagion department was continuing to contradict itself. It was not an easy task. We had to convince them that work had to be safe for us. Our colleagues were exposed to extremely long hours, and when they became infected, everything became harder. Even telling our bosses that we were becoming infected, they would not be lenient with us. We could not find replacement. We left women without care. Because of the pandemic, we lost our resting areas just to keep density of population low. We did not receive proper responses to health conditions due to getting infected within our work area. After the quarantine, we had to go directly back to work, whether we were okay, whether we were coughing, or whether we had any sequels. Not having the same conditions before we were infected, we were abandoned. And on top of all this stress, we started to get the darkest part of everyone's personality. We became hostile to one another. There was no prevention to take care of stress-loaded working environments, even though health professionals very much anticipated and predicted this scenario. They requested for additional efforts be made to prevent this situation. I want to say very sadly that matrons decided to promote medication or have stores in industry that have nothing to do with health instead of staying in the industry. We lost so many amazing people, so many human resources were lost. COVID was just a trigger for a time bomb that was already in place for many years due to the value of each person within our health team. Sounds ironic, but those of us who take care of people are the ones who are the least taken care of in our society, not just in my city, but across Chile. It's a reality that is I can see is global. Today, we are survivors of this environment that has to be reevaluated. I've been working in law for many years. I also have sequels, so I completely agree with this report, Sandra.
Personal experience. And so now we will move to our second part and run to find solutions. So we will share with the panelists solutions, and we'll come to Colin. Colin, what policies can help manage the impacts of the Great Resignation and migration?
Thank you very much. I would say I think we know that there is an increasing international mobility of health workers, and that's what our region is suffering from, and that's happening globally. We know that we don't have accurate numbers. Not only for mobility part, we have data and information constraints when it comes to health workforce. And we have different data from different sources and so on. So, but all this indicates certain things. I think we need to focus on mobility, and in addressing the health workforce mobility, we have a global tool, global governance tool, which is Global Code of Practice on International Recruitment of Health Workforce. I think the important issue is we really need to take it forward. All countries try to do that, and we see globally increasing commitment and implementation to the code. You know, in every 3 years, we do global monitoring, and we have done 4th, and next year we will have the 5th one. And in each monitoring cycle, we see progress. And if we look at the global code of practice, I think the most important issue in the global code is strengthening the health systems and health workforce in every and each country. I think that's the main issue. Each country should strengthen their health systems and ensure self-sufficient, sustainable health workforce. This is valid for source countries and for destination countries. That's the thing. And the second thing is increased international dialogue and collaboration. Thank you.
Thanks so much, Dr. Gullin. And then, of course, we would like to be talking with you the whole day, but the time is just running, and we will move to Marin. And of course, we want to know your thoughts about, of course, the gender international policies, and of course, to think about the message that you want to give to us, and also to the next panelists, also the same, please. Marin?
Yes, thank you very much. I try to be very brief. I think there are many different ways and aspects to consider, but I would like to highlight just 4 areas of concern I think that are crucial to addressing the decent work deficits and strengthening resilience. So first of all, I think we need to recognize the right of health and care workers to a safe and healthy work environment. As at the ILO and the International Labour Conference last year, it was adopted that a safe and health work environment is a fundamental principle and right at work. So that means that health and care workers have a right to occupational safety and health protection. And they do face a lot of occupational safety and health hazards in their daily work. Now, I think it's important that these occupational safety and health policies are gender responsive, taking also into account, for example, the protection that women health workers need during pregnancy, the social protection need for women, maybe changes in tasks and working time, etc., but also the aspect of harassment and violence and mental health, but also access to social protection. Second, I think we need to address the over-reliance on informal and volunteer work. It's still a consisting concern. A lot of health systems rely a lot on informal workers. And we see this is higher in the health sector than in other sectors, for example, than in education. And we need to understand that informal and volunteer work are hidden subsidies to the health system, and they need to be recognized, and they need to be remunerated, and they need to be formalized into the health system. This includes the way of addressing job insecurity, again, social protection, OSH, all that I have been mentioned before. Third, I think it's important to align policies with international labor standards. So the ILO, through its international labor standards, has a grown and a comprehensive system of instruments on work and social policies that aim at promoting opportunities for women and men to obtain decent and productive work in conditions of freedom, equity, security, and dignity. And a lot of those conventions are highly relevant for the health sector. First and foremost, of course, the Nursing Personnel Convention, but also Violence and Harassment Convention, Equal Remuneration Convention, Maternity Protection, Workers with Families Responsibilities, etc., etc. So I think it is important to also raise awareness and I think I would like there to echo also what my colleague Gülin from WHO said, is voice and participation and the need for dialogue. So our experiences show that practical and sustainable solutions to complex challenges are best found when all those who are concerned have a voice and work together. So social dialogue and dialogue is key, and that includes also the freedom to express concerns, for example, around the topic of gender equality, but also the right to organize and participate freely in dialogue, and where appropriate, negotiate. And this needs to be upheld also in emergency situations such as the COVID pandemic or any future pandemic. So I think I would like to end with a strong call for us to continue the dialogue, to work together, to raise awareness, and to ensure that workers and female workers and health workers in general enjoy their rights and are able to provide good quality services in respect of the rights and conditions of their work. Thank you.
Thanks so much, Marin. And finally, we go to Ben, and we ask for your last comment and call. What call should we make to the policymakers to Ben first?
Yeah. Well, thank you, Sandra. In May, Futuro Health was invited to share some of our best practices at the WHO convening. A key point, which is sort of echoing many of what other speakers said, is, of course, the U.S. also has to grow its domestic pool of health workers, and especially focus on the adults who would normally not participate in these or transition into these care roles. Why that's important at this moment in time for the U.S. It's the young population, the ones coming straight out of school, is declining. We also have a loss of enrollment in higher education from the pandemic. So figuring out creative ways in which to bring adults, diverse adults, into the workforce is key. And when Futuro Health started, we actually did 4 focus groups to look at why or what enables adults to be able to successfully make that transition. For those who wanted to have care roles, first, they found it was very, very complex to navigate the education process. And then second, even for those who made it into care roles, they were so burdened by debt, they were stuck on the bottom rung of the career ladder. So what resulted was an unusual collaboration between the employer and their unions, in this case, Kaiser Permanente and SEIU UHW, where they funded the creation of Futuro Health so that we could connect diverse adults into education journeys that would lead them to their healthcare credentials. And so what we also found was that, whether they became medical assistants, pharmacy tech, community health workers, it was not just the subsidized tuition or free tuition. It was also simplifying the education journey, and then also the confidence building that is needed for many adults who, have been out of school for a while and and haven't studied in the online modality as well. So there's several things that have to be addressed in order to successfully transition adults in order to grow this talent pool. So I just wanted to share that there's a lot of best practice, but the key is how do you a key policy is bringing adults who normally wouldn't participate in this workforce successfully into this workforce.
Great. Thanks so much, Van. And finally, Aileen, 1 minute for one message, please.
Un minuto para un mensaje, sí, claro.
Yes, of course. I want to make a call through this.
Lo mejor, que es el aprendizaje, que tenemos que ver el daño, ¿ya? Y repararlo, pero entre todas, ¿ya? Creo que tenemos que integrar la salud laboral en los espacios de salud, que no está integrado, ¿ya? Esto es fundamental para poder desempeñarnos en nuestras profesiones que están relacionadas en esta área en específica, porque la salud laboral está integrada en otras áreas, curiosamente, mucho más que en nuestra misma área. Tenemos que exigir en los estados el cumplimiento de las normativas internacionales y locales en cuanto a nuestra protección, ya que la Así que, y que no han recibido a cambio la rehabilitación necesaria. Hay muchas eh, eh, mujeres
To invite our last speaker, please invite Dr. Shabun Sharfaz, Women Global Health Deputy Executive Director, to deliver our closing remarks. Thanks to all of you.
Thank you so much. Thank you, everyone, for joining this global conversation, where today borders and time zones cease to exist. Your presence helped in making the world a smaller and a much more connected place. As we draw the curtains on this impressive gathering, I'd like to extend our heartfelt gratitude to our esteemed moderator, speakers, and panelists for gracing us with their profound insights. In the spirit of unity, we must recognize that the issues discussed transcend borders and affect us all. The pandemic revealed a staggering shortfall of 15 million health workers needed to achieve universal health coverage. Addressing the Great Resignation requires us to tackle its root causes, which are deeply intertwined with the gender inequities that persist within the health workforce. Women in Global Health stands proudly alongside the government of France in leading the Gender Equal Health and Care Workforce Initiative, as was introduced by Her Excellency Ambassador Delphine today. Over the past 3 years, this initiative has garnered commitments from 50 international organizations and NGOs, along with 18 governments. It is a testament to the growing momentum in our collective pursuit of gender equity in the health workforce. Let us remember that this is not merely a women's issue. It is the bedrock of robust health systems and global health security. In closing, I implore you to carry the torch of inspiration and determination that this event has ignited within us. Our journey is just beginning, and together we hope to script a story of triumph and transformation. I urge you to not only embrace the insights gained here, but also to champion our cause. I would encourage you to download and share the report widely. The link has been shared, for knowledge is the catalyst for change. Let us be the change we wish to see, and let our actions resonate far and wide, echoing the inspiring ideals we've discussed today. Together, we can make the world a healthier, more equitable place. Thank you, and stay connected and committed to the journey ahead. Thank you so much.